happy Dysphagia Awareness Month, and thanks to Heather for the invitation to present. We're going to segue a little bit and talk about fluoroscopy diagnostics and pay special homage to the esophageal screen. So the traditional role of the speech pathologist was very much just to focus above the upper esophageal sphincter. So really focusing on the oral phase of the swallow, the pharyngeal phase of the swallow, and it was further parsed out into oral, pharyngeal, oropharyngeal, and then esophageal phases. But we came into a territory dichotomy as well, in which gastroenterologists, ENTs were focused solely on the esophagus, and speech pathologists were historically just really hands off if we did see an esophageal problem. But we know now, more contemporary knowledge has led us to understanding that swallowing is a multi-phase phenomenon. We really can't just parse it out into an oropharyngeal problem or an esophageal problem, because there is a strong interplay between all phases of the swallow. And so that's why it's so important to not just focus on one part of the swallow, but to really appreciate the entire complex and complexity of the swallow as a whole. The issue with doing a monophasic evaluation or solely doing a lateral screen where we focus on the upper esophageal sphincter and up is that we are kind of missing the probable cause for a lot of our patients that come in and they say, ooh, I have something sticking in our throat. Very much what Dr. Damrose opened up and kind of paved the foundation for this talk. Also, if we're just focusing on solely the upper esophageal sphincter and up, we're failing to identify potential esophageal contributors to our patients' swallowing problems. And unfortunately, if we're only focusing on the upper esophageal sphincter and up, and we send a patient on their way saying, your pharyngeal swallow looks great, there's really nothing that alludes to your problem, oftentimes our patients are left to manage their symptoms on their own. And we know that amongst various disease processes, there are a strong interplay of oral, oropharyngeal, and esophageal phases across various disease entities. Systemic diseases such as scleroderma, head and neck cancers, which we know in our total laryngectomy populations, they have pharyngeal phase issues all the way down to esophageal phase issues. Neurodegenerative diseases such as Parkinson's and ALS. COPD patients also have pharyngeal issues coordinating adequate airway protection, but also have really high rates of esophageal dysphagia caused by gastroesophageal reflux disease. Patients with lung and esophageal cancers caused by obstruction from potential tumors, and then gastroesophageal reflux disease, which is the leading cause of solid food dysphagia in the United States. So when we think about the interplay between the oropharynx and the esophagus, the interplay both has a downstream effect, but also an upstream effect. And this is what's so important when we, as speech pathologists, dig in our arsenal, pull out compensatory strategies, and then we get our patients into the AP view or perform an esophageal screen. It's really important to discern whether or not a patient actually has esophageal abnormalities caused by the compensatory strategies that we prescribed, not necessarily any physiologic impairment. And what I mean by this is anything that we give our patients in terms of an oropharyngeal compensatory maneuver may have a downstream effect that we just often overlook. And when we think about some of these compensatory strategies, one of the most popular or common ones that we prescribe as speech pathologists are subsequent swallows. So if you have a patient with a lot of pharyngeal residue, you may have them do a subsequent swallow to help clear out that residue. But unfortunately, those rapid sequences of swallows may result in deglutitive inhibition or hinder esophageal peristalsis. And so that's something to consider when you get your patient into the AP view or do your esophageal screen, rather than jumping to, oof, they look like they have some dysmotility. Maybe it's because we gave them a compensatory strategy that induced that dysmotility. Oropharyngeal swallows, probably the most beloved exercise that we have in our arsenal, but also a wonderful compensatory strategy for our patients to help clear esophageal or pharyngeal residue. When we do an effortful swallow, we can also increase the distal smooth muscle peristaltic amplitude that was evidenced by Lever and colleagues when they evaluated patients using pharyngeal and esophageal manometry performing the effortful swallow. The Mendelssohn maneuver, this was data taken out of Dr. O'Rourke's group. Patients that did the Mendelssohn swallow or Mendelssohn maneuver while they swallowed, which is geared to elevate the larynx, thereby distending the upper esophageal sphincter, that particular movement reduced esophageal peristalsis. And the reason being is it caused panesophageal pressure, or uniform pressure from the upper esophagus all the way down to the esophagogastric junction, and resulted in poor or reduced esophageal peristalsis. So something to consider when we get our patients in, we give them a compensatory strategy. We also need to consider the downstream effects that those compensatory strategies may have. There's also an upstream effect. How many of our patients do we see on a daily basis when we get them into fluoro have cricopharyngeal bars, cricopharyngeal webs, Zenker's diverticulum, cricopharyngeal muscle dysfunction? Well, that constant pressure against an obstruction over time can slowly dilate the pharynx or balloon the pharynx. And when you have a balloon or dilated pharynx over time, it no longer wants to contract. You get reduced pharyngeal contractility or weakness, resulting in poor clearance of the bolus through the pharynx. So also something to consider that lower down at the cricopharyngeus level, we may have an upstream effect to the pharynx because of a pressure play. The anterior posterior plane, what does that give us in terms of information? Well, you can see this lovely fluoro here. The patient, his chief complaint was it just really took him a lot of time to swallow, to eat meals. And when we assessed him, this is what he was doing with his oral phase. So sometimes when we think of prolonged meals, we're automatically thinking esophageal stricture, or maybe residue, or maybe mastication issues. But oral phase can be quite evaluated in terms of symmetry and laterality. We can assess how the bolus flows through the pharynx or the upper esophagus. Maybe there's a lateral pharyngeal weakness causing more retention or less efficient swallow, and that's what this anterior posterior plane can give us. When we think about information from the esophageal screen, while it does not serve to be diagnostic, it can certainly raise our suspicions to maybe there is something going down lower in the esophagus within the esophageal body or the lower esophageal sphincter. So doing an esophageal screen allows us for a really rudimentary or elementary identification of some esophageal contributors to the patient's complaint. And furthermore, it allows us to really get our foot in the door in terms of referrals. We can flag our laryngology colleagues or GI colleagues and say, hey, I did a fluoro, I looked at the esophageal screen, and there was something a little wonky going on and that maybe needs a little bit further workup or a more expedient workup. Dr. Damrose also alluded to the quote-unquote referred sensation. And why is it important to look at the esophageal screen? Well, unfortunately, our patients are not the best at accurately identifying the location of where their associated complaints may be. Meaning that a lot of patients come in, they feel, oof, I feel something sticking in my throat, but actually 26% will have an esophageal etiology for that complaint. So nowhere up here, all lower down. And this was data taken from our center at UC Davis, in which we had patients point to their sensation of food sticking before we even engaged in the dynamic swallow study. Of 33% of patients who localized up here, 33 actually had esophageal abnormalities, gastroesophageal reflux disease, lower esophageal stricture, or hiatal hernia. So this is a picture that we took during fluoroscopy of some examples of referred sensation when we gave a barium tablet. We can see here that the barium tablet is retained lower down, but the patient is localizing up to the upper esophageal sphincter. On this further picture, we can see that that pill is retained all the way down by that lower esophageal sphincter, yet still that patient reports a more superior complaint for their dysphagia. So these are just some examples of what we may see on esophageal screen and really common complaints that lead patients to the sensation of food sticking in the throat. Number one, gastroesophageal reflux disease, which is really prevalent, but also esophageal dysmotility. And really the first presentation of when they come into our clinic is, I have food sticking in my throat. You get them in under fluoroscopy, get them in the lateral view, everything looks great, there's no residue, no pharyngeal residue. And then you further want to do a workup with an esophagram, manometry, and then they have esophageal dysmotility, which can occur along the entire esophageal body. It can occur proximal esophagus, distal esophagus. And esophageal dysmotility has various presentations. It's kind of a broad term that may incorporate absence or uncoordinated esophageal peristalsis, simultaneous contractions along the esophageal body, low amplitude contractions, or high resting pressures of the lower esophageal sphincter. And really the diagnostic tools to further parse this out are esophagram, esophagoscopy, and esophageal manometry. Achalasia, as Dr. Clark dovetailed into and gave us a good rendition, is impaired relaxation of the lower esophageal sphincter or absent peristalsis of the esophageal body. And that classic bird's beak presentation is what we can see in the anterior posterior view, but also in the esophageal screen. So here we go, we have that dilated esophagus up above, we have tertiary contraction squeezing down, and then that bird's beak appearance because of the inability for that lower esophageal sphincter to relax. And the big one that we certainly don't want to miss is cancer. It's not uncommon. I wouldn't say probably the most common complaint, but certainly it's something that we do see and need to keep on our radars, patients that do have the solid food complaints or the food sticking in the throat, that they may have those complaints because of an esophageal obstruction, like an esophageal cancer, or a mediastinal cancer, like lung cancer, where mediastinal lymphadenopathy is causing extrinsic compression on the esophagus, but also considering our patients and their oncologic treatments. Maybe they have strictures caused by radiation, maybe the chemotherapies or the radiation therapies have resulted in candidiasis of the esophagus. So when we think about the accuracy of our esophageal screen, how good is it? There's a lot of studies out there that have compared the esophageal screens and used various diagnostic tools as the gold standard for identifying esophageal abnormalities. And when we think about the sensitivity and specificity, fairly good across various modalities, such as the timed barium emptying study and esophageal manometry. When we identify esophageal abnormalities, whether that be motoric or an anatomical dysfunction, when compared to the esophagram findings, sensitivity and specificity are fairly good, and then also esophageal manometry, all within the same realm. So the accuracy of the esophageal screen, while not perfect, is certainly a tool that we can use to help further parse out what we need to do in terms of an esophageal workup. And I know that it is a bit of a contentious point for our speech pathologists that are working with radiologists in terms of they don't want to do an esophageal screen. That has kind of been the debate for several decades to come since fluoroscopy has been utilized within swallowing diagnostics. Luckily, fresh off the press is the consensus statement looking at video fluoroscopy, esophograms, and also the utility of the AP screen and the esophageal screen. This was from the ABA, the American Bronchoesophagologic Association, that describes and really clinically depicts how we should be using fluoroscopy. So that's something that we could share with our radiation colleagues to help get them on board for a more comprehensive assessment. If you have any questions, feel free to shoot me an email because I know we're close to time, but next year, welcome to UC Davis for the next dysphagia symposium.